Hello, welcome to my channel. My name is Bridget, I'm a nurse practitioner, and in today's video, I will be going over the most frequently tested items on the ACLS. I will also be providing a review. I have helped thousands of people pass the ACLS test. My previous video on ACLS was seen over 200,000 times. Make sure you stay until the end for a bonus. This video does cover the October 2025 AHA updates. If you would like a viewable version of this PowerPoint, then you may go to my website, www.nursingwithprofessorb.com. Viewable means you cannot download it. If you would like a downloadable copy, you may purchase it at my Etsy store for $4.97. You will find the links in the description below. Thank you for your support. Sometimes people complain that the video is too fast. As a reminder, you can go to settings, hit playback speed, you can slow the video down, you can speed it up, whatever makes your heart happy. Additionally, you can also pause the video if you need more time to read whatever's on the screen. This PowerPoint is for educational purposes only. You can pause to read. So I have included some BLS components in this video just because it's also going to be on the test. Even when you take an ACLS test, these questions will still be on there. This is the new priority, and it was changed several years ago in regards to what do you do when you find an unresponsive individual and you prioritize them accordingly. You do compression, airway, breathing versus they used to say ABC. The recognition of an unresponsive client begins with the whole tap, hey, 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 can you hear me? If they can't hear you, you want to activate 911. If there's several people around, you point to a specific person and you say, hey, you, can you call 911? And you can designate someone else to go get the AED. If there's a specific person there, just one person, you can tell them, call 911 and go get me an AED. If there's several people around, you can tell one person to call 911 while another person could go grab an AED. If help is around, request their assistance to activate 911 emergency system, get the AED. You want to check for a pulse. I will be cluing you in as we go through the PowerPoint on what specific things I remember being tested on. This is one of the questions that I remember is that when you're checking for a pulse, it should take at least 5 seconds, but no more than 10 seconds. And you can also check for breathing while you're doing this. Now, this is another test question. Agonal gasping is not breathing. And actually, another test question was like, agonal gasping is a lot of times the first sign of cardiac arrest. And agonal gasping, it sounds something like, like it's not a true breath. Check patient to see if they are breathing, if not breathing or not breathing normally, which is agonal gasping. And agonal gasping is on the test. It's not considered breathing. With the CPR sequence, you already know they will test that the compression rate for, this is all for adults, by the way, this is adult cardiac life support. I do have a BLS video. You can check that out if you want the parameters for children. But for adults, you want to compress at a rate of at least 100 to 120 compressions a minute, and the hand needs to be at the mid nipple line, which is the lower half of the breastbone. A lot of times they will test that too. They will also test the depth, the compression depth, that it needs to be 2 inches, but no more than 2.4 inches. The first 2025 update is that the Lucas device or mechanical compressions are not recommended unless the patient is being transported or the patient is going to be coded for an extended period of time. Why is mechanical CPR no longer routinely recommended? Because there's no proven survival benefit. Multiple large randomized trials found no significant improvement in survival to hospital discharge or neurological outcomes compared to manual CPR. Some studies even showed delays in initiation of compressions while setting up the device. Interruption risk. Applying the device often requires pausing manual compressions. Any interruption lowers coronary perfusion pressure and worsens outcomes. Potential for injury. Mechanical devices can cause more rib fractures, sternal fractures, or internal injuries if not perfectly positioned. And 4 is cost and practicality. Devices are expensive and require training, calibration, and maintenance, often not justified by clinical outcomes. So as you can see in the slide, the AHA allows selective use of mechanical CPR when the patient is being transported, for example, in an ambulance, helicopter, or cardiac cath lab, where consistent compressions are difficult, in cardiac catheterization or radiology suites when radiation exposure or space constraints limit personnel, and in a situation where there's prolonged resuscitation efforts, such as during ECPR, where manual fatigue becomes a concern. You want to allow for full chest recoil. If you don't allow for full chest recoil, there was another question on the test like that. And the reason why you need to allow full chest recoil is because you won't allow the heart to adequately fill between each compression. You want to minimize interruptions in chest compressions. It's recommended that interruptions be limited to less than 10 seconds. I believe that was on the test as well. Remember, there's different versions of this test, so it just depends on which one you get. You want to rotate the person providing compressions every 2 minutes.
So here's another change. It's still that if no trauma is suspected, you're going to utilize the head tilt chin lift. If suspected trauma, then you utilize the jaw thrust maneuver. However, if there is head or neck trauma and the airway cannot be opened with a jaw thrust and or airway adjunct insertion, then trained rescuers should open the airway using a head tilt chin lift. Basically, don't let them pass away due to lack of air.
For adults, it doesn't change. Whether it's single rescuer or multiple rescuer, it's always going to be 30 compressions to 2 rescue breaths. Ventilations with and without an advanced airway, this was updated in 2020. It is now 1 breath every 6 seconds. Before it was every breath every 5 to 6. 1 breath every 6 seconds for respiratory arrest with or without an advanced airway, and also for cardiac arrest with an advanced airway. And then you use this rate with a bag mask device if your local protocol is continuous compressions. Ventilate the patient 1 time every 6 seconds for a total of 10 per minute. You always want to look for visible rise of the chest to confirm adequate ventilations. So another test question was, if you see the abdomen rise, then you know the breaths are not going in the right place. If it's gastric inflation, then clearly that the breaths are not going in the right place. Defibrillation. Once an AED defibrillator is available, you want to use it immediately. And immediately upon defibrillation, you want to start CPR beginning with chest compressions. I'll skip over this part because we have gone over it. So again, this is on a test that you're checking for a pulse for a minimum of 5 seconds, but no more than 10 seconds. You need to know the depth of the compressions. You need to know that you need to allow for full chest recoil so that the heart can fill adequately in between compressions. And you want to provide breaths until you see visible rise of the chest in all patients. And you want to avoid excessive ventilations because this can lead to decreased blood flow. With the AED, you turn the AED on, you follow the AED prompts. When the AED becomes available, you immediately want to use it. And this is the only time that stopping CPR is appropriate. After this point, you will only use the AED on the 2-minute pause pulse check. If the AED analyzes and determines the victim requires defibrillation, do so only after clearing all bystanders and healthcare providers from the victim. Immediately upon defibrillation, resume CPR beginning with chest compressions. So this is where everybody yells before you defibrillate somebody. You of course make sure that nobody's touching them and you yell all clear, and then if it's all clear, then you deliver the shock. Adult pads should be used on adult patients. The AED can be used for a patient lying in snow. You want to clear the victim's chest. The AED can be used on a victim that was submerged in water. Of course, first you want to remove the victim from the water and wipe the victim's chest. The AED can experience difficulty if the victim's chest is hairy. So when possible, the victim's chest should be shaved with a medical razor or pads firmly placed to ensure chest contact. Most kits nowadays do have a razor in there. If there's not a razor, you could always take the pediatric pads and give them a quick wax job. So you just put the pediatric pads on and boom, you rip it off quick so that you remove the hair.
So there have been changes on how do we handle a foreign body airway obstruction in adults. So in the past, only infants received the 5 back blows and then the 5 chest thrusts. But now for adults, they say in a responsive choking adult, we are to perform 5 back blows, that's new, and then 5 abdominal thrusts, and you alternate between them the same way we do back slaps and chest thrusts for infants until the object is expelled or the person becomes unresponsive. So I'm a nerd. I like to know the reasoning behind things. So if you want to know the reasoning too, or if you were wondering, why did they change it? Studies of adults with FBAO showed that back blows were associated with improved rates of FBAO relief and fewer injuries compared with abdominal thrusts. So the recommendation for alternating sets of 5 back blows and 5 abdominal thrusts is based on the value of consistency with existing infant and pediatric guidelines that use this approach.
I did not see anything on foreign body on ACLS. I see that on BLS, just a heads up. Just some additional pearls is that, of course, you want to always ensure the scene is safe prior to approaching a patient. That was a test question. It was like, what do you need to do before approaching a patient? Something along the lines. And it was like, ensure the scene is safe. If the victim has no pulse and is not breathing, CPR is required.
This is more for BLS, but October 2025 update. Two-finger technique is out in infants. When performing chest compressions on an infant, the two-thumb encircling hands technique or the heel of one hand should be utilized. As a reminder, if there is a neck injury and you cannot get an airway, you may now use the head tilt chin lift if the jaw thrust fails. But again, that's if the jaw thrust fails.
To provide adequate breaths, the rescuer should do their best to seal the patient's nose and mouth when providing breaths. If no method for safely providing breaths is available, then hands-only CPR should be used at a rate of 100 to 120 compressions per minute. Suctioning of a patient should be limited to less than 10 seconds. The oropharyngeal airway should be measured from the corner of the mouth to the angle of the mandible to ensure adequate size and placement. That is also a test question with the OPA. That is also frequently tested. Breathing. Visible rise of the chest is a key indicator that breaths are effective in all patients. Don't provide excessive ventilations that can cause gastric inflation. When providing rescue breaths, again, adults should only be ventilated once every 6 seconds. With an advanced airway in place, compressions are constant with no pauses, and ventilations are provided once every 6 seconds for all patients. Continuous waveform capnography is the preferred method for monitoring the placement of an endotracheal tube. That is on a test. Continuous waveform capnography is the preferred method for monitoring the placement of an ET tube. This is also on the test. The end tidal carbon dioxide should maintain a reading of at least 10 during CPR. If the numerical reading decreases below 10, then it is assumed that chest compressions are not adequate. High quality chest compressions are achieved when the end tidal carbon dioxide value is 10 to 20 millimeters of mercury. The structure or universal approach to the cardiac arrest emergency does not change regardless of profession or setting. CPR should take place in 2-minute increments, allowing for approximately 5 cycles of 30 compressions to 2 ventilations. Upon completion of a 2-minute CPR cycle, a pulse should be palpated for at least 5 but no more than 10 seconds. If a pulse is felt, then the post-cardiac care should be initiated. If no pulse is felt within 10 seconds, the rescuers should switch positions and compressions should be immediately repeated. If the patient requires electrical therapy, aka defibrillation, CPR should be continued while the defibrillator charges as to minimize the interruptions. When electricity arrives at a cardiac arrest incident, it is the only acceptable reason to stop CPR. The defibrillator AED should be used immediately upon the use of electricity or confirmation that electricity will not be used. CPR should be started beginning with chest compression. That's important in the mock scenario, that immediately once the shock is delivered, that chest compressions start immediately. Shockable rhythms. The way I remember which rhythms are shockable is with my little jingle. And it goes D fib for V, fib and pulseless B tach. Don't defib asystole, you won't get them back. D fib for V, fib and pulseless B tach. Don't defib asystole, you won't get them back. That being said, I do know that in real life settings that they do occasionally shock what appears to be asystole, because the rationale is that maybe it's a very fine V fib and we're going to shock them to see if we can get them back. But on a test, remember, this is me preparing you for a test. In the test world, you do not shock asystole. That is the incorrect answer. That is the incorrect intervention. So defib for VFib and pulseless V tach. And defibrillation, the biphasic initial is 120 joules to 200. If unknown, use maximum available. Second and subsequent doses should be equal and a higher dose may be considered. Monophasic is 360. And use the suggested manufacturer joule setting on the unit. With the 2020 updates, a lot of times what they're saying now is we're going to refer to manufacturer settings versus them actually testing you on the joules that should be delivered. Drug therapy for shockable rhythms, epi. We're going to do epinephrine 1 milligram every 3 to 5 minutes. Amiodarone, first dose is 300 milligrams, second dose is 150 milligrams with a max of 450, or lidocaine, first dose 1 to 1.5 milligrams per kilogram, second dose 0.5 to 0.75 milligrams per kilogram. I do have a video on the changes between the 2015 to the 2020 guidelines. If you want to check that video out, feel free to check that out. Non-shockable rhythms include pulseless electrical activity, which is PEA, and asystole. What are we doing for these non-shockable rhythms? We're doing drug therapy, epinephrine 1 milligram every 3 to 5 minutes. And you want to treat the reversible causes of H's and T's. If you're listening to this, I will read it to you for those that are maybe cooking, cleaning, and just listening to this. So reversible causes are hypoxia, hypovolemia, hypothermia, hypokalemia, hyperkalemia, hydrogen ions. And the T's are tension pneumothorax, toxins, tablets, thrombosis, cardiac tamponade. And a note is that known causes will never supersede epinephrine administration. I can tell you from all the years I've been taking this test that I've never been tested on the H's and T's. I've always been tested that we need to know epinephrine. Return of spontaneous circulation. Indication of life, return of pulses is the first step. Second step is we want to manage the airway and early placement of endotracheal tube. You want to manage respiratory parameters. This was also a change, but the O2, we want to remain at between 92 to 98%. You want to start with 10 breaths per minute. And the partial pressure of carbon dioxide should be between 35 to 45 millimeters of mercury. You want to manage hemodynamic parameters. Systolic BP should be greater than 90. The MAP should be greater than 65. You want to obtain a 12-lead ECG. You want to consider emergent cardiac interventions, such as if a STEMI is present, if they have unstable cardiogenic shock. These are the ending steps of ROS. If they are awake and they need other critical care management, you evaluate and treat rapidly reversible etiologies, and you want to involve expert consultation. If they can't follow commands, we have the targeted temperature management, which is code COOL. Obtain brain CT, EEG monitoring, and other critical care management.
These are 2025 updates for medical emergencies. So the external defibrillator pad placement for women, it says that you may adjust the bra and you don't have to remove bra. And the reason why this was changed is because women experience significantly lower rates of public access defibrillation compared with men. The need to apply pads or paddles directly to the bare chest may be a contributing factor. So the option to adjust rather than remove a bra could mitigate factors like a rescuer's discomfort with exposing a woman's chest. The initial vascular access recommendation is that it's recommended that healthcare professionals first attempt establishing IV access for drug administration in adult patients in cardiac arrest. Intraosseous access is reasonable if initial attempts at IV access are unsuccessful or not feasible for adult patients in cardiac arrest. Why did they change this? Because a systematic review and meta-analysis found that the use of IO access compared with IV access did not result in statistically significant improvement outcomes. This systematic review noted lower odds of achieving sustained ROSC for the IO route compared with the IV route. Next, we have that for adults in cardiac arrest with a shockable rhythm, give epinephrine only after you've tried defibrillation and it hasn't worked. And lastly, they are recommending higher first shock energy settings, so greater than 200 joules, are preferable to lower settings for cardioversion of atrial fibrillation and atrial flutter.
Additional ACLS medical emergencies with bradycardia, assessment of the patient is critical, and the treatment, and we're going to treat symptomatic bradycardia. The key word here being symptomatic, with atropine 1 milligram every 3 to 5 minutes with a max of 3 milligrams. If atropine is ineffective, you want to consider transcutaneous pacing and or consider dopamine 5 to 20 micrograms per kilogram per minute. Consider epinephrine 2 to 10 micrograms per minute infusion. With SVT, first you want to have the patient try vagal maneuvers. Adenosine 6 milligrams rapid IV push. Wait 1 to 2 minutes. If no conversion, administer 12 milligrams. The way I remember this, I just remember that like 6 plus 6 equals 12. I don't know, like It's just the number doubles. That's how I remember adenosine. Like you just double the number. So 6. If no conversion, then you administer 12. If SVT persists, you want to seek expert consultation. If unstable, keyword here again is unstable. If unstable, you want to perform synchronized cardioversion and refer to your specific device's recommended energy level to maximize first shock success. So this is where we're seeing again the changes between 2015 to 2020. They used to specify joules and now they're saying just go by what your specific device recommends. VTAC with a pulse. Remember that we do not defib VTAC with a pulse. We defib VTAC. Defib for VFib and pulseless VTAC. So for VTAC with a pulse, you want to administer 150 milligrams of amiodarone over 10 minutes. If unstable, perform synchronized cardioversion. Refer to your specific device's recommended energy level to maximize first shock success.
So they usually don't test atrial fibrillation on the ACLS except for the rhythm. However, I'll cover it. So you administer diltiazem 0.25 milligrams per kilogram over 2 minutes. Remember that with the new update, if we have unstable atrial fibrillation, we perform synchronized cardioversion greater than or equal to 200 joules.
At one time, and someone told me that they were tested on it. So I'm including the treatment here.
Once again, the treatment for atrial flutter is the same. Diltiazem, 0.25 milligrams per kilogram over 2 minutes. And if unstable, perform synchronized cardioversion greater than or equal to 200 joules.
Again, follow your specific hospital's policy or your company's policy. Acute coronary syndrome, where there's indication of a possible STEMI, you want to immediately obtain a 12-lead ECG. You want to administer 162 to 325 milligrams of aspirin if no contraindication is there. Administer nitroglycerin sublingual or translingual. Caution if there's right ventricular AMI present, or caution if they've been known to use sexual enhancement drugs, aka Viagra. You want to administer oxygen. So once again, think of Monabi, which is your morphine, oxygen, nitroglycerin, aspirin, and beta blocker. But they don't have beta blocker here, but in the hospital, in the real world. You want to administer morphine in 2 milligram increments for pain relief. So this was definitely on the test. The door to balloon time is less than or equal to 90 minutes. For stroke, you perform the Cincinnati Stroke Scale Assessment. Alert the receiving hospital as soon as possible. I believe something was on the test about that. You want to perform a non-contrast head CT within 25 minutes of arrival at the ED. And remember non-contrast because we're not sure if it's hemorrhagic or ischemic. You want to start fibrinolytic therapy if negative for hemorrhage. Remember, only do fibrinolytic therapy for ischemic stroke. Team dynamics, open loop communication is used to ask questions during the resuscitation. Closed loop communication is used to confirm repeat orders. So doctor orders something and you repeat back. You said, this is what you mean. Do you mean this? Administer now? Yes. Team leaders are important aspects because they have the ability to address team members immediately if an intervention is incorrect, and they also orchestrate the entire emergency situation and clearly delegate tasks. Tasks should be directed based on the scope of practice, and team members who cannot perform a task should make the team leader aware and request an alternate task or role. I believe this was a test question as well. So if you feel that something is outside of your scope of practice, or you feel like you cannot do it, you've never done it before, you don't feel comfortable doing it, please speak up and say something. This is not a situation where you can fake it till you make it. You know, in the nursing profession, nurses are basically being hit left and right now with criminal charges. So this is not a situation where you fake it till you make it. Let them know that you don't feel comfortable doing whatever your role was assigned if you don't know how to do it. The medical emergency team or rapid response should be used as a resource if the patient condition is worsening, not just as a means for assistance during cardiac arrest. I will say that definitely there is no shame in calling rapid response if you feel like your patient is declining and you're not sure why they're declining. Especially if you're a new RN, utilize your rapid response team. They're just another resource. Don't feel bad about it. It's better that you call them, and it's better that you call them before they code than wait till they code and then you call it. You know, like that famous quote says, an ounce of prevention is worth a pound of cure.